Thank you to the organizers for giving me this opportunity to talk to you about a little bit of history of the ICRP in medicine. Well, the use of radiation has been very much related to medicine from the beginning, and so were also the early injuries, of course. The X-rays were soon used for X-ray diagnosis, but a little later for radiotherapy as well. And the discovery of radioactivity, particularly 2 years later, the radium was immediately used in radiotherapy. So at the beginning, the early injuries were quite natural because there was no measurement of radiation, no quantities, no units, no instruments to quantify, and therefore people use their hands for checking the output of the machine if everything was in order, and therefore the hand was very much used in medicine and also in research. The first X-ray tubes had no shielding, not only the X-ray tube itself, but also the high voltage terminals, cables. Also in the head, John Daniels, a few months after the discovery of the X-ray, he made a tentative radiography of the skull of a colleague, of the skull, of the head, and then he realized 3 weeks later that the spot is now perfectly bald, meaning that there was a hair loss because of the, of course, long exposure time. It was that time the image receptors were very low sensitivity, of course. And also in dentistry, Dr. Balkhoff discovered also some loss of hair of male patients in dentistry. So in summary, the injuries in the first 2 decades were primarily on researchers and some manufacturers, but certainly on radiologists and radiation therapists. Also in the First World War, there were many mobile X-ray units, very primitive, which of course caused a number of injuries as well. So the demand of and the concern of the medical community on the effects of radiation triggered the need for an international committee, and this was created in the Second International Congress of Radiology, of which the first chair of the committee was the young 30-year-old Rolf Sievert, who became again a chair 27 years later. So the name of the committee was then International X-ray and Radium, because these were the two main uses of radiation: X-ray for diagnostics and therapy, and radium for therapy. So the first set of international recommendations in 1928 basically had 3 rules already. It was devoted to occupational protection in medicine, mainly in these uses of radiation, and the distance, shielding, and time were the 3 major pillars of these recommendations. In addition, there were recommendations on the electrical side, because the high voltage was also a problem. For example, if you see the recommendation 11, distance required the operator of X-rays to be as remote as practicable. And in the case of treatment, as in the case of therapy, it was suggested that the operator be completely outside of the X-ray room. Also, the shielding, there was a requirement to shield the X-ray tube, and also the operator should be afforded at least 1 millimeter of lead. The time was limited to the working hours, because at that time there was no feel about the exposure conditions. There was such a long time, exposure times, half an hour for a radiography, that obviously the limitation came through the working hours. screening examination should be conducted, so the fluoroscopy should be conducted as rapidly as possible. These were the very first recommendations of the ICRP. And the successive recommendation elaborated on that, mainly again on X-rays and radium until the year 1950. In the year 50, there was already many other applications of radiation, and therefore many other protection issues to take care of. And then the organization was renamed to International Commission on Radiological Protection. And the parent organization continued and continues to be today the International Society of Radiology, in which the commission was given birth. So, and then committees were appointed, up to 6 committees, later became 5, and then 4. As you see, the medical part is a little bit more diluted. It is in all of these points: external radiation, internal radiation. So all of this is medical involved, but no longer focused on. But until the creation of Committee 3, the renaming Committee 3, that we will see in a few minutes. Up to 1958, all publications of the ICRP were in scientific journals. There was the series of publication that as we know it today, it didn't exist until publication 1. And in this publication, one thing was abolished, which is the issue of vacations and working time, because, as it was said, with that time permissible exposure levels, no special radiation, no special treatment of radiation workers with respect to working areas and length of vacation was needed. The report stated also explicitly that there was no recommendations were given on medical exposure. So protection of patients were at that time still excluded from the recommendations. But it began relatively soon. In publication 9, it was mentioned, the UNSCARE report, which was giving a lot of emphasis to the increase in medical exposure, and it was recognized that medical exposure could be reduced without loss of medically important information. And soon after this statement, once this statement was explicitly said by the ICRP, then a task group was formed to work on X-ray diagnosis, of protection of patients. And the task group prepared publication 16, which was entirely devoted to patient protection. It recognized that radiation protection should not create any difficulty in achieving the diagnosis. Diagnosis is the most important, but it may be stated that measures for radiation protection would contribute to the highest standard of clinical radiological practice. So it was the case that it was not only a dose reduction possible, but even by doing this quality control and assurance, then even the practice itself benefited from these protective measures. So the technical content of this publication were astonishingly were very much, I'll say, valid today. First of all, it took care of all the parameters that lead into optimization, although not with this name. There was the property of the X-ray beam, the beam quality, filtration, and so on, the size and position of the beam, of course, the collimator, organ shielding, the effect on those of the anti-scatter grids that could be, in theory, could be removed for small patients where not much scatter radiation is expected. Sensitivity of the recording system, also film screen combination. The processing of the film was very important for protection. and the reduction of number of intakes. So these points are almost as they are valid today. And now in 1977, then recognizing the importance of the medical uses of radiation, the Committee 3 was renamed and was called Radiological Protection in Medicines as we know it today. And one of the main points explicitly recognized at that time was that matters requiring particular attention include the protection of patients. So these are the chairs of the Committee 3 up to now. I started for Charlie Meinhold, Julian Linietsky, Henri Jamet, Fred Medler, Claire Cousins, and today Eliseo Bagnon. Already Charlie Meinhold started with preparing a comprehensive radiation protection of patients in diagnostic radiology, which was published already in 1982. Then a few years later on radiotherapy, and another one on medicine, on nuclear medicine. We, the physicists, were very happy with these publications. There was a comprehensive treatment of the issues, but we will see later that it was not sufficient. ICRP 34, just to give an example, first of all, reviewed the parameters that influencing the exposure much more exhaustively as the previous publication, say 16. The methods for optimization, provided education and training recommendations, and also even appendices with the results of transport calculations that were already available in the 80s. So on organ dose calculation, as I said, this was a very exciting for the physicists. But in 1997, when Fred Medler took over the chairmanship of the committee, he made the following reflection. These comprehensive reports were very useful, very much used by radiation protection specialists in hospital, medical physicists, regulators, but certainly not by the medical community. One could not expect that the gastroenterologist would have time to read the whole report on the whole of radiology or a cardiologist. So he thought it is important to address particular audiences, specific audiences within the medical community. And so, improve the situation that the impact of those publications was limited. So that a decision was made, I remember this discussion, a decision was made to identify first, and we made a first brainstorming on specific demands by specific audiences within the medical community, then address those demands in form of concise, focused reports, worded as possible and in plain language, but of course still in a scientific manner and consistency with the other ICRP recommendations. It was also decided that to accept translation by obviously authoritative professional societies in local languages, so not restricted to French or Spanish, but also any other languages, local languages in the world. We will see a couple of examples. And also developed a series of slides free, available in the ICRP web, so that everybody could use it in the teaching. And the result of this was, the first one was the pregnancy and medical radiation. The discussion was what are the worries of the medical community, and in front of the patients, but also for the workers, professionals working in medical radiology. So the pregnancy and medical radiation addressed this issue, focused on pregnancy for all the possible audiences in this case, and for patients and workers. And of course, nuclear medicine, diagnostic radiology, therapy. And this, an example of translation in Korean language and also in Spanish, and then you see the sets of slides up there at the right. Then there was a need for guidance to physicians, particularly also, it became also very useful for students, and the name was Radiation and Your Patient, so clearly addressing them directly, a few pages only, but dedicated to give the basic knowledge needed by the general practitioners before prescribing, but also for many other doctors being somehow related to the use of radiation, and also for the students in the hospitals. In addition, in the same publication, there was a few other pages dedicated to the existing, a review of all existing approaches for diagnostic reference levels. There were many, you know, the European, American, and others. So we made a review, and then the committee gave recommendations, additional recommendations on the use of them. Then education and training, the guidance we said before, it was very useful for education and training, but it was needed also a more detailed series of syllabus for the different professionals, and more recently, publication 113 was issued. I don't dwell on those because Professor Bagnot dealt with them yesterday. So in radiation therapy, the demand, what was the demand? The demand was the worry about accidental exposure, lessons learned. So therefore, we devoted time to dedicate to publication 86, which was on conventional radiotherapy. And 10 years later, there was already knowledge enough to publish a second publication on new technologies in external beam. But the new approach was so flexible that it was possible to devote to particular issues a concise report. And more recently, the report on ion beam radiotherapy was issued, and my colleague, Professor John Ekura, will address, elaborate on this publication. But also, high-dose rate brachytherapy was needing attention. And even more specifically, the prostate cancer with permanent implants had particular problems. So we also, with this concise method, then we could address any topic on any reason except or any need, reacting on any need by the medical profession. So fluoroscopy and interventional, the first publication was this avoidance. Of course, the first worry was avoidance injuries in medical exposure, in patients, of course, in the skin, but also in the professionals, the development of cataracts. And a few years later, in the publication 117 on the fluoroscopy done outside the radiology department, which is gastroenterology, urology, orthopedic, and so on. So it was there was a need for a publication on these issues, and also, of course, for a specific group of cardiologists, because cardiology is one of the major perhaps use of interventional procedures. Digital radiography, as Professor Bagnot mentioned yesterday, the X-ray detector, the image detectors have the potential to reduce those because they are to some extent more sensitive, but reality was the opposite. And therefore, preparing the people for the transition from the conventional to digital was very important, and then publication 93 was published in this series. Also in computer tomography, this is a very successful series because, first of all, it was the first one, single slide, was mainly devoted to helical CT, or spiral CT, as you call it. And then a second one was very much needed a few years later, 4 or 5 years later, the multi-slide CT, and more recently, the cone beam CT. Before these publications, manufacturers were more keen of obtaining short scanning times and very good image quality. The dose was also in the agenda, but not so highly in priority. And after these publications, the whole debate of triggering reduction of those was, of course, not only because of the ICRP, there was also, and at the same time, there was the International Action Plan on Patient Protection, launched by the WHO and the agency, the World Health Organization and the International Atomic Energy. And all this synergy contributed to very much weight given to reducing exposure. And now the manufacturers are talking about sub-millisievert CT, which is coming in the near future. So it is a natural, fortunate evolution. And also this approach of concise report allowed to focus on special group, for example, pediatry. And we, in publication 121, the attention was devoted to pediatric radiology, but also other type of examination, not only radiographies, also CT, interventional, everything which is related to done on children. So in summary, there is already 20 very concise, very small, something like 40, 50 pages, and in some cases a little more, publications from the year 2000 to date. And Committee 3 current work, I will not dwell on it because Professor Bagnot said yesterday we are working on protection in occupational protection in brachytherapy and interventional radiology, interventional procedures, justification, a framework for justification, diagnostic reference level, which is already approved by the Commission for publication, for public response to the draft, radiological protection in therapy with radiopharmaceutical, and we are starting also to work on radiation protection in medicine related to individual radiosusceptibility, I suppose in collaboration with Committee 1. So the conclusions are that since the birth of the ICRP in 1928, the ICRP has been closely related to the protection in medicine. It was born from the Society of Radiology in response to growing interest and growing concerns on the effect on the medical community. During the first almost 30 years, the recommendations were devoted to radiological protection of the professionals in medicine. In the 50s, the name was changed to protection in medicine. In 1997, in the 50s, the name was changed to International Commission on Radiological Protection. In 1977, this was done, the Committee 3 was devoted to protection in medicine, as we know it today. In the 80s, there were comprehensive publication to protection in radiology, nuclear medicine, and radiotherapy, and later the concise publications, 20 concise publications, addressing specific concerns from specific audiences within the medical community. So I thank you for your attention.